Thyroid storm and myxedema coma. Thyroid storm and myxedema coma from the Ministry of Health Pockets Manual in Emergency from Saudi Arabia Ministry of Health. Overview. Thyrotoxicosis refer to any state characterized by a clinical excess of thyroid hormone. Thyrotoxicosis refer to any state characterized by clinical excess of thyroid hormone. Thyroid storm represent the extreme presentation of thyrotoxicosis. Thyroid storm represents the extreme presentation of thyrotoxicosis. And myxedema coma used to describe the severe life-threatening manifestation of hypothyroidism. Myxedema coma used to describe the severe life-threatening manifestation of hypothyroidism. The term myxedema coma itself is a misnomer, as patients do not usually present with a frantic coma, but more commonly have altered mental status or mental slowing. Myxedema actually refers to non-biting, puffy appearance of the skin and soft tissue related to hypothyroidism. Myxedema actually refers to non-biting, puffy appearance of the skin and soft tissue related to hypothyroidism. Clinical presentation. History. There is some question to evaluation of thyroid storm. Thyroid storm. History of thyroid disease. Symptoms of hyperthyroidism. Tremor, agitation, weight loss, nervousness, heat intolerance, proximal weakness, palpitation, menstrual irregularity, thyroid manipulation, medication changes, psychological stress as trauma, infection, exertion, recent anesthesia, recent iodinated contrast, infectious syndromes. So, points in history for evaluation of thyroid storm: history of thyroid disease, symptom of hyperthyroidism, thyroid manipulation, medication changes, psychological stress, recent anesthesia or recent iodinated contrast, or infectious syndrome. Question to evaluation: myxedema coma, history of thyroid disease, symptom of hypothyroidism, weight gain, hair loss, fatigue, dry skin, voice changes, depression, constipation, menstrual irregularity, medication change, oven menorrhagia, psychological, physiological stress, has infection, trauma, cold, exposure, major life changes. The physical examination. The patient with thyrotoxicosis classically presents as febrile, tachycardia, widening pulse pressure, tremulous, weakness, weight loss, palpitation. And the patient with hypothyroidism classically presents blood pressure low to elevate, skin changes, hypothermia, pseudomyotonic deep tendon reflex. The patient with hypothyroidism classically present with the blood pressure low to elevate, skin changes, hypothermia, pseudomyotonic deep tendon reflexes, depressed mental function, non-biting edema, weight gain. The differential diagnosis in thyroid storm: hypoglycemia, hypoxia, sepsis. Hypoglycemia, hypoxia, sepsis, encephalitis, meningitis, hypertensive encephalopathy, alcohol withdrawal, benzodiazepine barbiturate withdrawal, and opioid withdrawal, heat stroke. These are the differential diagnoses in thyroid storm, hypoglycemia and hypoxia and sepsis, encephalitis, meningitis, and hypertensive encephalopathy, and withdrawal in alcohol, benzodiazepine, barbiturate, opioids, and heat stroke. So, differential diagnosis in thyroid storm, hypoglycemia and hypoxia, sepsis and heat stroke, encephalitis, meningitis, hypertensive encephalopathy, and withdrawal, alcohol withdrawal, benzodiazepine, barbiturate withdrawal, and opioid withdrawal. Differential diagnosis in myxedema coma. Differential diagnosis in myxedema coma. Also hypoglycemia, hypoxia, and sepsis, and hypothermia due to environmental exposure, cerebrovascular accident, acute myocardial infarction, intracranial hemorrhage, hypopituitarism, adrenal insufficiency, hyponatremia, GIT bleeding, conversion disorder. So, differential diagnosis in myxedema coma, hypoglycemia, hypoxia, sepsis, and hypothermia, cerebrovascular accident and acute MI, and intracranial hemorrhage, hypopituitarism and adrenal insufficiency, hyponatremia, GIT bleeding, and conversion disorder. The workup: TSH, T4, and T3, full chemistry, cardiac marker, B-type natriuretic peptide level, serum lactate level, random cortisol level, urine analysis, urine pregnancy test for beta-HCG, ABG, ACG, chest radiography, echocardiography, CT head lumbar puncture if indicated. The management: pre-hospital, support of airway and breathing, vital signs, circulation with emergent transport to emergency department, blood glucose level, pre-wearing for hypothermic patient, warm humidified oxygen, chemical and physical restraint, cardiac monitor, and continuous pulse oximetry. In hospital care: the management in hospital care: management of myxedema coma, intravenous replacement of thyroid. T4 is administered in dose of 200 to 500 microgram IV. Pediatric dose is 10 mcg per kg per day IV, divided into 6 every 6 or 8 interval. Empiric glucocorticoids, hydrocortisone at 100 mg IV, and the pediatric dose is from half to 1 mg per kg IV every 8 hours is the recommended dose. Thyroid storm. 3-step treatment of thyroid storm. Step 1, Step 2, and Step 3. Step 1, the goal is to block peripheral effects of thyroid hormone. The treatment provides continuous intravenous infusion of beta-blocking agent. The effect slows heart rate, increase diastolic filling, and decrease tremor. Slowing heart rate, increase diastolic filling, decrease tremors. This is step number 1. The treatment of thyroid storm to block the peripheral effect of thyroid hormone by using infusion of beta blocking agent. Step 2. Stop the production of thyroid hormone. The goal provides the treatment provides antithyroid medication, propyl uracil-1 or methimazole and dexamethasone. The effect antithyroid decrease synthesis of thyroid hormone in the thyroid. The propyl uracil slow the conversion of T4 to T3 in periphery. The dexamethasone decrease the conversion of T4 to T3 in periphery. Step 3. The aim to inhibit hormone release. Give iodide 1 to 2 hours after antithyroid medication. This decrease of thyroid hormone from thyroid. Disposition admission must be in ICU department. Thank you.